All right, and can you guys hear me? Okay, very good. Thank you. All right, so it looks like we do have a quorum. Thank you.
I
We'll
can't
go
hear you,
ahead.
McKay.
You can't hear me.
I can hear you. Just fine.
Okay. Well, I will keep going. Brian, we good? Technical difficulties. Well, looks like he left, so we'll go ahead and get started. I'm sure he'll join up here in just another minute. But it looks like we do have a quorum today, and so we are excited to get together again. First thing we need to do is review the minutes from our May meeting, which have been sent out. Why don't we take a moment to look those over, and if anyone approves, please let us know and we'll get those approved.
Motion to approve.
All right, thank you. And any second?
I'll second.
Oh, all right, thanks, Dr. Sloan. All in favor, say aye.
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 And any opposed? All right, and do we have any that abstain? I think Dr. Sheffield wasn't available or wasn't at the meeting, so.
That's correct. Yeah, I did not, I wasn't present.
Okay, very good. Thank you. All right, so next would be, we have some housekeeping. Brian, did you want to take care of that? Or Brian, are you with us again?
Okay, why don't
Brian,
we come back to Brian?
Okay. The next would be the DUR board update.
Thank you. So the DUR board met in July to review the IPKISA and approve using the rare disease PA for IPKISA. The board also received training on the Utah Open Public Meeting Act from Tony in July. The board did not meet in August. We resumed meeting in September to review the annual DUR report and also review the Aduhelm PA, insulin U500 PA, and monoclonal antibody PA. We will meet in October to review the lidocaine topical. Thank you.
Very good. You guys have been busy. Thank you so much. Brian, are you back with us to do some housekeeping, or should we move on to the topic of the day?
Are you able to hear me?
Yep,
Great.
now.
All right. So housekeeping, we just, the term is up. It's time for the annual nomination and election of a committee chair. Dr. Robinson has served us well, and re-nominate him, nominate someone else, that's at the discretion of the committee. Call for nominations from whoever's like to select somebody or volunteer somebody or themselves.
Is anyone interested in taking this on? It's I really enjoyed it. I think it's been about 3 years now, and so it's really been great. So I'd suggest if anybody wants to give it a try, then do it.
Just a general question, McKay. Have you found as chair time commitment outside of the committee? Is that different or similar?
No, it's pretty similar. Just a couple more emails and just wanting to be a little extra prepared for the meetings. But it's for sure not. It's not significant. But I think you would do great, Cole, if you want to give it a try.
And I'm sure other committee members had a similar question, if anyone is.
And I would love to nominate you, Cole, if that's something that you would be interested in trying for a little bit.
Sure. Yeah. And if obviously if there's other interests as well, I'm happy to defer as well. So
I nominate Cole.
All right.
thanks, Dr. Sheffield.
That's
I think-
usually how these things go, by the way.
Yeah, I'll second that.
All right.
All
Any other
in favor-
nominations before we call for the vote? All right, with that, all in favor of Cole Sloan as the committee chair, say aye.
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 Any opposed?
Aye.
Who was that opposed, or was that just late? So no one opposed, is that correct? And are there any abstentions? All right, Cole, you'll be the next committee chair.
All right. Thank you.
Very good. Well, we'll go ahead and move on then to the wakefulness promoting agents, and looks like Dr. Gonzalez has that, so we'll go ahead and leave it to her.
All right, good morning. Let me get these slides up for you. All right. So the wakefulness promoting agents we are reviewing today have FDA approved indications that span excessive sleepiness associated with narcolepsy, obstructive sleep apnea, and shift work sleep disorder. As you can see in this table, the older agents, modafinil and its R enantiomer armodafinil, are approved for the treatment of excessive sleepiness associated with each of the three disorders, while the newer agents, solriamfetol and pitolisant, are approved for a subset of these indications. Solriamfetol is approved for use in narcolepsy and OSA, and pitolisant is approved only for narcolepsy. But pitolisant is the only agent of these four medications that has been shown to reduce cataplexy events in narcolepsy. These are all oral medications taken on a daily basis and are approved for use in adults only. Narcolepsy is a rare but chronic disorder characterized by excessive daytime sleepiness, The majority of these patients also experience cataplexy, in which paralysis lasting a couple of minutes can occur with the daytime sleep attack. Other possible features in narcolepsy are low hypocretin levels, hallucinations while falling asleep or upon awakening, and poor quality nighttime sleep. Anxiety and depression are also associated with this condition. The US guideline we have for narcolepsy is quite dated. It was last published in 2007 by the American Academy of Sleep Medicine. In this guideline, modafinil and armodafinil were among first-line recommended pharmacotherapies for improving excessive daytime sleepiness in adults with narcolepsy. A European guideline published this year adds the newer agents solriamfetol and pitolisant as first-line options for excessive sleepiness. This guideline also recommends pitolisant among first-line therapy for cataplexy. Combinations of different drug classes may be used to target cataplexy or other symptoms of narcolepsy. Shift work disorder, also referred to as shift work sleep disorder, affects up to a third of night shift workers. While an adjustment in circadian rhythm may naturally occur for some people, others experience inadequate adjustment and suffer from this disorder. It is characterized by sleep disturbances when sleep is intended, leading to impairments in alertness and cognition. Not only can shift work disorder lead to serious occupational accidents or injury to oneself or others, insufficient sleep can take a toll on social and emotional functioning. In the 2007 American Academy of Sleep Medicine guideline that addressed this disorder, modafinil was recommended to improve alertness during the night shift. Other options were timed melatonin administration, hypnotics to promote daytime sleepiness, and a weaker recommendation for caffeine to improve alertness. A more recent systematic review by Cochrane reported moderate quality evidence in support of armodafinil and modafinil to increase alertness in those with work shift disorder, low quality evidence in support of melatonin for improving daytime sleep duration, and a lack of evidence supporting hypnotics for improving sleep duration or quality in patients with this disorder. In 2013, it was estimated that 14% of men and 5% of women in the US met criteria for obstructive sleep apnea. Although it is not clear exactly what proportion of these patients have symptoms that may benefit from the use of a wake-promoting agent, OSA is cited to be the most frequent diagnosis contributing to daytime sleepiness. Experts advise considering wake-promoting agents for OSA-related daytime sleepiness that is persistently burdensome, diminishing quality of life, work productivity, or safety. In the 2009 ASAM guideline, modafinil was recommended as adjunctive therapy to optimize positive airway pressure. Solriamfetol was approved 10 years after this guideline, or after the ASAM guideline, and now serves to as an additional option for this condition. We have scant information regarding the direct comparative effectiveness of these agents. We found only 2 head-to-head randomized controlled trials with pitolisant versus armodafinil in the setting of adults with narcolepsy with or without cataplexy. Pitolisant dosed at the higher end of the approved dosage range reduced daytime sleepiness similarly to modafinil 100 to 400 milligrams per day. Yet pitolisant failed to demonstrate non-inferiority to modafinil. One study suggested that modafinil outperforms the lower dosage range of pitolisant for improving patient-perceived sleepiness. Nonetheless, in both of these studies, there were no significant differences found between these agents for secondary endpoints, such as maintenance of wakefulness, attention level, or cataplexy rate. Based on the head-to-head data from the trial that is fully published, adverse events occurring in a greater percentage of modafinil-treated patients versus the pitolisant arm included abdominal pain, diarrhea, dizziness, withdrawal symptoms, and anxiety, while headache and insomnia occurred in more pitolisant-treated patients. No other direct comparative studies were identified for other drug comparisons or indications. Regarding safety, 3 of these 4 products are scheduled for controlled substances with potential for abuse. Pitolisant is the exception. Intolerability to these agents can be due to headache or nausea, which are 2 of the most common side effects. Other less frequent side effects include anxiety, dry mouth, decreased appetite, insomnia, and GI symptoms. This table summarizes contraindications, warnings, or precautions in potential drug-drug interactions based on product labeling. Patients should be warned of rare but serious hypersensitivity reactions possible, particularly with armodafinil, modafinil, and pitolisant. As a class, these medications should be used cautiously in patients with psychiatric history and dose reduced or discontinued if psychiatric symptoms worsen or develop. Since these agents can slightly increase blood pressure and heart rate, patients with hypertensive histories should be well controlled before starting treatment, and increased monitoring should be considered in patients with known cardiovascular disease. Pitolisant has a warning for the potential to prolong the QTc interval, and there are unique drug-drug interactions possible with each of these agents. These 4 wake-promoting agents reviewed are not currently on the Medicaid preferred drug list. However, they are accessible through a prior authorization if treating FDA-approved conditions or off-label sedation related to multiple sclerosis for modafinil. The newer agents, solriamfetol and pitolisant, require initial trial and failure of armodafinil or modafinil. Based on direct comparative information available, these agents appear similarly effective for improving sleepiness symptoms in their indicated disease states. The agents that are now generic, armodafinil and modafinil, are approved for 3 conditions of excessive sleepiness, while the newer brand name medications are approved for a subset of those conditions. Pitolisant is the only agent of these 4 medications that is established for reducing cataplexy in narcolepsy. And as we reviewed, each agent has unique safety considerations, which the provider must weigh against patient-specific comorbidities and the background medication regimen. Taken all together, you may consider having at least 1 wake-promoting agent as preferred on the PDL and continue to offer access to non-preferred products via prior authorization. Regarding utilization in the Medicaid fee-for-service population, from January of this year through July, we had only 35 claims attributed to a total of 14 patients, mainly for modafinil, followed by solriamfetol and armodafinil. And that's all I have for you today.
Thank you so much. Did we have any public comment today? I don't see any planned on the agenda, but
We may have lost Brian. We do not.
okay.
And I have a question for Dr. Gonzalez, if we're there yet. Oh, I'm sorry. That's the next item.
Yeah, and I think we're moving on to that, to any discussions or questions that we may have to open that up for discussion right now. So go ahead.
So this is Joe with Medicaid, one of the pharmacists with Medicaid. Dr. Gonzalez, this distinction of narcolepsy with cataplexy, my understanding is armodafinil, something like 80% of the patients in their clinical trials also met that definition too. So, and armodafinil showed effectiveness in those patients too. So is that distinction of narcolepsy with cataplexy really meaningful when comparing these newer agents to the older agents?
So these agents, you kind of have to think about the symptoms. So armodafinil does work for improving excessive daytime sleepiness, but it's not established for reducing cataplexy rate. So you might have a patient where they may benefit on this, sleepiness wise from armodafinil, but you might have to also have them on a anti-cataplexy agent that works on cataplexy. So right now, of these four, it's pitolisant is the only one that has actually been shown to reduce cataplexy symptom. But like you're pointing out, you can use armodafinil, modafinil, all of these for improving sleepiness in narcolepsy with or without cataplexy. Does that help answer your question?
Thank you. Again, my understanding, I had a provider send in a note that armodafinil should work because he or she pointed out, 80% of the patients in their clinical trials also had cataplexy with their narcolepsy, and it was effective. So
yeah, and for this project, I didn't look specifically on I mostly focus on head-to-head studies. I didn't look specifically on what information was reviewed by the FDA when armodafinil was, under review for approval, and I didn't see anything about armodafinil showing significant reduction in cataplexy rate. But what I have read in guidelines is they do point out that those older agents, they're not proven to reduce cataplexy. So it would be expected for it to work for reducing sleepiness symptoms, but it's not established for cataplexy. It may or may not, it hasn't really been looked under the microscope, I think, for reducing that specific symptom.
I think that addresses the question I was about to ask is it a matter that it has not been studied or that it has been studied and shown not to be effective, the other agents for cataplexy?
I kind of felt like a little of both, it's been out there for a long time. And I think if it would have had this robust reduction in cataplexy, they probably would have, I assume they would have tried to go for that unique indication, that we see with pitolisant now, which is you see both of those symptoms represented in the product labeling.
Okay. But to your knowledge, it has not been studied.
To my knowledge, it hasn't been like an endpoint that it has, been proven to be significantly impactful on.
Okay. Thank you.
The 2021 guidelines, as per your handout, sort of also suggests that the mechanism of action of the wakefulness promoting agents, the modafinil, armodafinil, and the third one, sorafenib, are not expected to actually reduce symptoms of cataplexy. Those patients often are treated with combination therapy with a wakefulness promoting agent. And if the cataplexy is significant and interfering with function, they add an anti-cataplectic drug, which commonly includes an antidepressant, certain antidepressant agents, and or sodium oxybutyrate.
Thank you for that. Any other questions or concerns from the committee members or those listening that have any questions that may we want to think about before we make an action?
I think I'll just make a quick comment that, you know, the purpose of this review is, you know, to determine whether it would be appropriate to manage this class of drugs on the preferred drug list, and so that we could have those tools available to us.
Is there any concern, Brian, about these being used extremely off-label for, you know, ADHD or any other disease states that may not be approved?
Well, we still have the prior authorization in place, whether or not we manage through the preferred drug list. And so this would just be another tool, and using the prior authorization, you know, we can control that. If someone's, you know, submitting if someone wants to use WAKIX for ADHD, that's probably going to get denied through the PA process.
There are some fairly established off-label uses, one of which is mentioned, at least one of which mentioned in the review, which includes daytime sleepiness due to multiple sclerosis. It is also sometimes used as an adjunct for antidepressant treatment. And I believe that going through the prior authorization process, those are actually handled by that process, so that it's not those indications are being assessed and the drug is not being used. Drugs are not being used inappropriately.
Mm-hmm. Any thoughts or motions on or any issues regarding safety and efficacy and how that would impact placement on the preferred drug list?
Yeah, trying to formulate. I think it's reasonable to include on the PDL. Unfortunately, the only head-to-head data we have from pitolisant and modafinil, it seems that modafinil was superior is the wrong word, I think, statistically for the study they ran, but pitolisant didn't reach non-inferiority, but has the broadest indication with that cataplexy. So I'm not sure how to...
Sometimes when motions are made, an example that has been used before is, all agents are equally safe and efficacious with the exception of such and such, which is more efficacious, less efficacious, more safe, less safe. So that's one way that we've handled motions in the past where there are these cases of something that is a little different.
Great, thanks for the example, Brian. I guess what I would propose is all wakefulness promoting agents are equal and efficacious with the exception of modafinil was found to be more efficacious than pitolisant, but at least one agent should be included on the PDL.
As preferred. When you say one agent should be included on the PDL, you mean as preferred, correct?
Yes, yeah, at least one agent should be preferred.
Okay. I'll second that motion. Let's see. McKay, you're on mute.
Sorry. All right. Well, thank you, Cole. All in favor of Cole's motion?
Aye.
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 And do we have any opposed? All right. And do we have any that abstain? Okay. Do we have any other motions that we feel would be appropriate at this time? Brian, do you have any suggestions or concerns?
No, just I mentioned that next month, or not next month, next meeting in November, we will be discussing antiretroviral combinations, and we'll have our annual training, which was supposed to take place today, but something came up and that wasn't possible today. And yeah, that's all I have.
Okay. Well, I think if we've covered the wakefulness promoting agents appropriately, then we can go ahead and adjourn the meeting at this time. All in favor?
Aye.
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 And any opposed?
All right.
All right.
Well, thanks, everybody.
Very good.
Congratulations, Cole, on being our new chair. We'll have that next time.
All right. Looking forward to November. Thank you.
Cole, if you have any questions, you know how to get a hold of me.
Absolutely. Thanks, McKay.
All right. Thanks, guys.
Bye-bye.